A 39-year-old man is admitted to the hospital by his brother. Evaluation of increasing forgetfulness and confusion during the past month. His brother reports that the patient has been drinking heavily, eating very little, and been slightly nauseated and tremulous. He wanders at night because he cannot sleep. On admission to the hospital, intravenous IV administration of 5% dextrose in water is initiated. 2 hours later, the patient has ophthalmoplegia and is completely confused. So, what would you think should be the next steps in this management? What have you picked out from this story that stands out to you and would further drive or probe your diagnosis?
Well, the first thing to note is the alcohol use and eating very little. The alcohol use is something that can affect the liver a lot, which is responsible for detoxifying substances. And the liver is also important for the formation of many vitamins, such as B1, B2, B3, B12. So from this, I'm already looking at potentially a thiamine deficiency. And this is also typical of a syndrome known as Wernicke-Korsakoff syndrome. Absolutely, which is a memory disorder. Now, the reason this stands out, why? Is because 2 hours later the patient has late ophthalmology. Interesting. Why did it progress so quickly after the 5% dextrose in water? Well, 5% dextrose in water is known to aggravate thiamine deficiency because of certain reactions, and this causes the symptoms mentioned. So definitely the next step in management is large doses of vitamin B1 thiamine being administered intravenously so that it can be absorbed and used. And next steps, I would definitely recommend this person stay off alcohol for a significant period of time and being very careful in treatment such as dextrose in water. Very important that we don't have any combinations that can cause problems in the body. Definitely. Is that ready for the next one? Okay. 45-year-old man has had a 1 week history of increasing neck pain when he turns his head to the right. He also has had a pins and needles starting in his neck and radiating down the right arm into the thumb. His symptoms began 3 months ago when he developed severe pain in his neck and right shoulder. Neurological examination shows limitation of motion on turning neck to the right. There is a 4+/5 weakness of the right biceps and decreased pinprick of the right thumb. Deep tendon reflexes are 1+ in the right biceps and brachioradialis, all others are 2+. So, what is the most likely diagnosis here, and what are the next steps?
So, I think when you've brought about the concept of the neck pain, the pain radiating down his, I don't know about radiating down his arm, but the sensory neural changes down his arm.
Down.
So your decreased pinprick, your pins and needles feelings, that looks to me as some sort of brachiopathy. So looking at the brachial plexus. So this would be part of the cervical spine, most likely. And I'm looking and thinking about a radicular nature, compression of an upper cervical segment, maybe C6. This is indicative from the fact that the bicep reflex is weak. And there's also the motor symptoms that we see with the thumb and with the biceps. So obviously the musculocutaneous nerve of the biceps, the thumb, your medial and your ulnar nerves, primarily the medial nerve would really dictate your motor function, and it does have inputs from your cervical segments, especially C6.
Okay, could you actually add on to that, briefly explain how the cervical root compression? Yeah.
Yeah, so I think it would be of radicular nature, pressing both sensory and motor.
So how does compressing the motor root actually lead to this decreased sensation?
It doesn't decrease sensations from compressing the sensory roots and
Compressing roots in general, nerve roots. How does it affect sensation?
by compressing the sensory nerves
What does that
that
do?
go to down that dermatome and innervate all the skin associated with that nerve. Compressing that means you'll have either increased or decreased firing of that nerve and can cause your pins and needles, so sensations when you don't have any, or no sensations at all, depending on local factors that will affect that. That will also cause further degeneration and potentially even neuronal death as well.
Does it affect the action potentials?
Yes.
Okay. And lowering visual acuity. What following tests would be obtained? Just as a quick fire question. Would it be an EEG, a CT scan of the head? An EEG. Absolutely. I agree. It's very important. Now, a 19-year-old woman, 19 now, comes to the physician because of a 3-month history of intermittent drooping of her left eyelid, called ptosis on the right. Slight ptosis on the right. Each evening, occasional difficulties chewing or swallowing, 2 episodes of double vision, and resolved by the following morning. Which of the following is the most likely diagnosis?
Yes. So in this case, when you have a young patient, it takes the degenerative element out of the equation. So in this case, I am thinking of myasthenia gravis, a neuroinflammatory condition, an autoimmune nature that results in autoantibodies against acetylcholine receptors, or in most cases, about 90%, or in smaller scaffold proteins associated with receptor density. So myasthenia gravis will result in muscle weakness, can be seen in her left eyelid drooping, so loss of your palpebral superioris, tarsal muscles, and furthermore, you have difficulty in chewing and swallowing, so loss in your muscles of mastication, pharyngeal constrictors, whether longitudinal or circular. You have issues with your vision because you lose control of your extraocular muscles. So you're not able to synchronize your eye movements precisely, and you get differing visual fields. So yes, the fact that it shows also this morning, evening cycling, this um, this fatigable nature where at the end of the night, day, your symptoms are worse, is really reminiscent of myasthenia gravis as this autoimmune condition targeting your nicotinic acetylcholine receptors at the neuromuscular junction and decreasing the recruitment of motor units.
Okay. So, let's end on a bang. A 72-year-old man is brought to the physician because of a 2-day history of confusion, disorientation, and lethargy. He has no weakness, cerebral infarction 1 year ago, treated with daily aspirin since then. He's awake but lethargic. His temperature is 38.9, pulse is 82 per minute, respirations are 16 per minute, blood pressure is 144 per 88 millimeters mercury. The physical examination shows no other abnormalities. He is disoriented to place and time, but recognizes his daughter. Now, the great thing about this case is we have a lot of lab studies, which we're going to blitz through and see whether they're in the normal range. First of all, what is a cerebral infarction?
Cerebral infarction is death or necrosis of brain tissue.
Okay. So,
from a vascular cause.
okay. So hemoglobin, 11.1 grams per deciliter. That looks normal, even to me. Leukocyte count, 12,200 per millimeters cubed. Okay. Segmented neutrophils, 60%. Eosinophils, 2%. Monocytes, 8%. Lymphocytes, 30%. Interesting distribution. Obviously, eosinophils and monocytes will be lower considerably. Let's get into the serum. Sodium ions, 130 MEq per liter. Is that normal? Okay. Chloride, 92 MEq per liter. Is that normal? Potassium, 4.1 MEq per liter. Can I just point out the difference in potassium and sodium here? Sodium is going to be much higher outside the cell. Is that why we see these high levels? Okay. Potassium is also inside the cell, maintaining the gradient in the cell. Carbonic acid, 21 MEq per liter. Is that normal range? Urea nitrogen, 29 milligrams per deciliter. Creatinine, 1 milligram per deciliter. Okay. Now into the urine. pH 7, normal. Specific gravity 1.02. Now, white blood cells 10 per HPF. What do you make of that?
White blood cells should not normally be found in the urine. This signifies some sort of um, it signifies some sort of renal damage. The fact that you've got white blood cells, and as I can see, you've got red blood cells in the urine as well. And you've got vesicular flexing.
Red blood cells, yeah, 6 per HPF, yeah. Bacteria is also positive.
Yeah. And nitrates are also positive as well, which indicates some sort of bacterial infection. So I think in this case, with the elevated white blood cell count in general, you have your increased renal permeability in your glomerulus. So you're filtering out these red blood cells and white blood cells, big, large cells, and that would normally not be present in the urine. So I think in this case, given the nature of the patient and the presence of bacteria in his urine, I think it's likely that this patient has some sort of bacterial infection, urinary tract infection in this case, and I think it's causing him to be in a state of delirium, which would explain some of his cognitive symptoms of confusion and disorientation.
And what would be the next treatment mechanisms in this patient? What would you be looking to do first of all?
I think the best thing to do would be to target the bacterial infection as it's the underlying cause of this presentation. So I'd definitely be looking at giving antibiotics.
Antibiotics? Antivirals, perhaps?
From the bacteria count, I probably
The
would,
bacteria count, yeah.
but if it would be some sort of viral infection of the urinary tract or the kidneys themselves, I'll definitely consider antivirals or vaccination